Hello everyone, welcome to our new channel. Today in Clinical Case 3, we are going to discuss three topics: Epistaxis, Deafness, and Stridor. Firstly, let me introduce our team to you. We are third year, Group 8 Nigerian class. Epistaxis is going to be discussed by Zainab, Aisha, Imam, and Zahraa Cassim, while deafness is going to be discussed by Khadijat Haliru, Khadijah Halima al-Fadrai, and Halima Shuaib. And lastly, Stridor, which is going to be discussed by Khadijah Aminu, Radwa Zaghlul, and Arwa Fadlallah.
Assalamu alaikum. My name is Zainab Abubakar. I'm gonna talk about history of epistaxis. So epistaxis is defined as an acute hemorrhage from the nostril, nasal cavity, and nasopharynx. It is a frequent emergency department complaint and often causes significant anxiety in patients and clinicians. And the most common cause of it is dry air. Most cases of epistaxis is minor and insignificant, but it may be severe and life-threatening, and it can be more serious. So, history of epistaxis. Firstly, when a patient comes to you, you ask for his personal history: name, age, sex, occupation, where he works, residence. It might contribute to the causes of his condition. Then after that, you ask the main reason why he's here. Then history of presenting complaint: the onset, duration, cause, severity, aggravation, relieving factors, frequency, how often it occurs, what causes it, how long before it goes, and then special habits: if he's a smoker, alcohol, drugs, an addict. Then past history: if he has had past medical or surgical history, if he takes medication such as analgesics and anticoagulants, things that cause epistaxis, or herbal remedies or allergies, if he had any surgical history. For example, if he had an operation surgery regarding his nose that might have been triggered, that caused epistaxis. If he's hypertensive or diabetic, everything about his past medical and surgical history is very important. And then his family history: if any of his family has history relating to epistaxis, or if one of them died because of it, anything related to any vulnerable information relating to what is wrong with him is very important. Yes. So all in all, in obtaining a history of epistaxis, the clinician should try and establish the quantity, the frequency, severity, as well as to uncover an underlying factor that contributes to the condition. So if you ask your patient, you hear what happened, everything about his life, his history, it may uncover things that he might have forgotten to mention, which will help his condition. Thank you.
Causes of epistaxis or nose bleeding. Discussed by Aisha Imam.
Good day, everybody. My name is Aisha Imam, and I'm going to be talking about the causes of epistaxis. But before I go into causes of epistaxis, I would like to talk more on the littles area. As we all know, the nose is richly supplied by blood from branches from the internal carotid artery and external carotid artery. So the littles area is an area situated in the anterior inferior part of the nasal septum, just above the vestibule, and it is where 5 arteries supplying the nose anastomose. These 5 arteries are anterior ethmoidal artery, posterior ethmoidal artery, septal branch of superior labial artery, septal branch of sphenopalatine artery, and the greater palatine artery. The anastomosis of these 5 arteries forms a vascular plexus called the Kisselsbach's plexus. Now, I'm explaining the littles area because it's an area that is known to be one of the most common sites for epistaxis to occur, and is also an area that is exposed to the drying effect of inspiratory current and fingernail trauma. The causes of epistaxis or nose bleeding are divided into local and general causes. The local causes of epistaxis are, firstly, the most important local cause of epistaxis is idiopathic, meaning epistaxis can occur due to unknown causes, mostly in 90% of cases. And epistaxis can occur due to trauma, maybe fingernail trauma. If a person picks his nose a lot, he can cause trauma to the nose and cause bleeding, injury of the nose, fractured nasal bone, fracture skull base after nose surgery, hard blowing of the nose, and violent sneezing. Inflammations like acute rhinitis, nasal diphtheria, and acute sinusitis can all cause epistaxis. Chronic rhinitis, rhinitis sicca, tuberculosis, syphilitic septal perforation, granulomatous lesion of the nose like rhinosporidosis can also cause epistaxis. So foreign body in the nose can also cause epistaxis, like if there are beads, buttons, rhinolith, or any living foreign body like maggots or leeches in the nasal cavity. Neoplasms, benign neoplasms of the nose, sinuses, and nasopharynx, like maybe a hemangioma or a papilloma, can cause epistaxis, or malignant neoplasms like carcinoma or sarcoma could also cause epistaxis. Atmospheric change can also cause epistaxis due to high altitudes or sudden decompression, like in Cassim disease, and also deviated nasal septum can cause epistaxis. General causes of epistaxis is due to general conditions of the body, like if cardiovascular system disease, such as hypertension. If a person has hypertension, he's most likely to have epistaxis, and hypertension is the most common cause of epistaxis in the elderly. Also, atherosclerosis or mitral stenosis can all cause epistaxis. Disorders of blood and blood vessels, like if a person has aplastic anemia, leukemia, purpura, or hemophilia, it can all lead to epistaxis. If the person has deficiencies of some vitamins like vitamin C deficiency or vitamin K deficiency, can also lead to epistaxis. Liver disease, like if the person has deficiency of factor 2, 7, 9, and 10, it could lead to epistaxis. Drugs, if the person uses a lot of salicylates like aspirin and other analgesics, or use of anticoagulants, can cause epistaxis. Mediastinal compression. So a mediastinal tumor raises venous pressure in the nose and causes epistaxis. And acute infections like chickenpox, measles, influenza, whooping cough are all known to cause epistaxis. Also, vicarious menstruation is epistaxis coming at the time of menstruation. So the sites of epistaxis. So in most cases, epistaxis occurs in the littles area. About 90% of epistaxis occurs here. And epistaxis can also occur above the middle turbinates in case of hypertension, mostly due to bleeding of anterior ethmoidal arteries, or below the level of middle turbinates, mostly due to bleeding of sphenopalatine artery, or in the posterior part of the nasal cavity, blood flows directly into the pharynx, or it could be diffused from both the nasal septum and the lateral wall, often seen in general systemic disorders. Also, epistaxis can occur in the nasopharynx. Thank you so much for listening.
First aid and management of epistaxis. Explained by Zahraa Cassim Desai.
First aid and management for epistaxis. First, stop the bleeding. Place patients in sitting position upright to decrease venous congestion. Lean patients slightly forward to avoid swallowing of blood. Do not allow patients to lean backward or lay down, as it may cause blood to block the airway. If possible, get patient to gently blow their nose and apply a piece of cotton soaked in nasal vasoconstrictive drops or adrenaline. Breathe through the mouth while using the index finger and thumb to pinch the soft part of the nose just above the nostrils for about 10 minutes. Applying this pressure often stops the bleeding, and cold compress may be applied to cause reflex vasoconstriction. If bleeding continues after 10 to 15 minutes, continue to pinch for a further 10 to 15 minutes. If still bleeding, then seek medical attention. Note: to prevent rebleeding, do not pick or blow your nose and do not bend down for several hours. You can also gently apply some petroleum jelly to the inside of your nose using a cotton swab or your finger. Number 2. See a healthcare provider immediately if the bleeding does not stop after about 30 minutes, there is excessive bleeding making it difficult to breathe, or the patient is feeling faint or dizzy. Nosebleed happens after the severe head injury or blow to the face. The patient has been taking blood thinners or has a bleeding disorder. Number 3. Medical treatments. When medical attention is needed for epistaxis, it is usually because the problem is either recurrent or severe. Treatment depends on the clinical picture, and some examples are foreign body removal if this is the cause of the nosebleed, medication adjustments or new prescriptions if needed. Reducing or stopping the amount of blood thinning medications can be helpful. In addition, medications for controlling blood pressure or blood coagulation may be necessary. Some other examples are nasal packing. Anterior packs are when a 50 centimeter Vaseline gauze is packed into the nose in layers from below upwards and removed after 24 to 48 hours. Posterior packs are when anterior packs fail or when the bleeding point is a posterior lesion, then they are used. Gauze packing is used, but balloon tamponades are easier to do and more comfortable to the patient and thus is usually preferred. Cautery of bleeding vessels. This procedure involves applying a chemical substance, example 50% silver nitrate, or heat energy, which is electrocautery, to seal the bleeding blood vessel. A local anesthetic is sprayed into the nostril first to numb the inside of the nose before the procedure. Surgical treatment. This is used when cautery of packs fail and epistaxis is severe. Examples are arterial ligation, which can be done to stop the bleeding, or surgical repair of a broken nose or correction of a deviated septum if these are the causes of the nosebleed.
Short notes and history of deafness. Discussed by Khadijat Haliru.
Deafness, otherwise called anacusis, is partial or complete hearing loss that may affect one or both ears. Levels of hearing impairments vary from a mild to a total loss of hearing. Elderly adults suffer most often from hearing loss, and it can create difficulties with social interaction and at work. Hearing loss related to age usually affects both ears and is due to cochlear hair cell loss. The most common cause of hearing loss in children is otitis media and may affect their ability to acquire spoken language. A substantial number of hearing impairments are caused by environmental factors such as noise, drugs, and toxins. Deafness can also result from inherited disorders. When recording history for hearing loss, we ask the patient's name and their age, and we take their vital signs. Then we record history of present illness, review of systems specific to hearing loss, past medical history, family history, and social history, and finish off with physical examination. For history of present illness, we take the patient's chief complaint and we ask whether it is both ears that are affected or a single ear, and whether the hearing loss is specific to one sound or to all sound. Then we ask for onsets, whether the hearing loss is constant or intermittent, whether there have been any precipitating events. We ask for the progression of hearing loss. We ask for previous episodes, whether any previous episodes have occurred. We ask for alleviating factors, aggravating factors, and for aggravating factors, we ask the patients if they find it specifically difficult to hear in a group setting, and we ask for associated symptoms with hearing loss. For review of systems specific to hearing loss, we ask for trauma. We ask if there has been any headache. We ask if there is nausea, vomiting, rash, skin changes, recent infections, dizziness, recent exposure to sudden loud noise, tinnitus, ear pain, ear discharge, weakness, numbness, or tingling. For past medical, family, social history, especially for past medical history, we ask the patient if they have ever had cancer and if chemotherapy was involved. We ask about allergies and for the patient to describe the allergic reaction if they have allergies. We ask about the medications they are using, ask about previous hospitalizations and past surgical history. We ask about family history related to deafness. We ask about their work life, for the noise level at their workplace, and if they use ear protection. We ask about home life, if they drink alcohol, if they use recreational drugs or tobacco. Out of focus physical examination, the physician should wash their hands and use respectful draping. Then, when carrying out the head, eyes, ears, nose, and throat examination, the physician should palpate the head, inspect the ears, palpate the ears, carry out an otoscopy, a Raise test, and Wells test. For neurological examination, a focused examination of the cranial nerve should be done, as well as a focused examination of hearing.
And now we are going to talk about causes of deafness. Discussed by Khadijah Owaisu.
Assalamu alaikum. My name is Khadijah Awesu, and today I will be discussing the causes of deafness. So as we all know, there are different types of deafnesses and each have different causes to it. These types include the conductive hearing loss, the sensorineural hearing loss, and the mixed hearing loss. The first one I'll be discussing is the conductive hearing loss. This one is caused by diseases of the external or the middle ear. For the external ear, we have several causes, which could be the congenital atresia, which is the congenital maldevelopment of the ear canal. We can have an excessive buildup of earwax, which is actually the commonest cause of deafness. We could have foreign body impaction. We could have infection with inflammation and fluid buildup, and we can also have allergic causes. As for the middle ear, the different causes can include a perforated eardrum. It could also be caused by trauma like otitic barotrauma and fracture base. We could have inflammatory causes, which could include the suppurative otitis media and so on. We can also have a malfunction of the ossicles, where there could be otosclerosis or there could be congenital absence or fixation of the ossicles. And the last one here is the defective eardrum anostation tube, where there might be inflammation like salpingitis or there can be an obstruction in the tube by a tumor or adenoid. So the second one I'm going to discuss is the sensorineural hearing loss, and this is also known as the perceptive hearing loss. This one is caused by dysfunction of the inner ear, the cochlea, the auditory nerve, or the brain. This type of hearing loss is usually due to lesions in the cochlea or lesions in the cochlear nerve or even brain lesions. It may occur as a result of congenital deformities like that of conductive hearing loss or inflammation, in this case known as the labyrinthitis. It could be also due to infections or head trauma. Long-term exposure to loud noises, especially high-frequency sounds such as those that work at airports, factories, DJs, it is another common cause for hair cell damage, and hair cell damage is actually not able to be fixed. The third one I'm going to talk about is the mixed hearing loss, and this one is actually a combination of both, which is the conductive and the sensorineural hearing loss. Long-term ear infections can damage both the eardrum and the ossicles, and sometimes a surgical intervention may restore the hearing, but it is not always effective in some cases.
And now we are talking about tuning fork test. Discussed by Halima Ibrahim Uthman.
Tuning fork test. The tuning fork test provides a reliable clinical method for assessing hearing loss. They are most useful in patients with unilateral hearing loss, which is purely conductive or purely sensorineural. So in case of patients with bilateral or mixed hearing loss, usually it is assessed by pure tone audiometry. The Ring test and Weber test help distinguish between conductive hearing loss and sensorineural hearing loss. So the equipment used for this test is a 512 Hz tuning fork. Note, you should be in a completely silent room for this test. How to do Weber's test. Weber's test compares between bone conduction between two ears. To perform Weber's test, strike the fork against your knee or elbow, then place the base of the fork in the midline, high on the patient's forehead. Then you ask the patient, do you hear the sound louder in one ear than the other? If so, which ear is louder? If the patient is unclear, you may ask if they hear it everywhere. Be careful not to ask a leading question. If a patient has a unilateral conductive hearing loss, the tuning fork sound will be heard louder in the deaf ear. If the patient has a unilateral sensory neural hearing loss, the tuning fork sound will be heard louder in the normal ear. How to perform ring test. This test compares between air conduction and bone conduction in the same ear. So you explain this to the patient. I'm going to put a vibrating tuning fork in two positions, one touching the bone near your ear and one a short distance from your ear. I want you to tell me which position you hit the tuning fork the loudest in. So you first strike the tuning fork against your knee or elbow and place the base against the patient's mastoid process for a few seconds. Then promptly lift the fork and place the vibrating tip about 1 centimeter away from the external auditory meatus. After that, you ask the patient, in which position did they hear the tuning fork loudest in? If a patient can hear best when the tuning fork is in air, which is positive ring test, then air conduction is better than bone conduction. So there is definitely no conductive hearing loss. If the patient can hear best when the tuning fork is on the mastoid, which is negative ring test, proving that bone conduction is better than air conduction, this is demonstrating a conductive hearing loss. But there's a false positive ring test or reduced positive ring test. This happens in sensorineural hearing loss where air conduction is better than bone conduction as it is in positive ring test, but they are both reduced, giving a false or reduced positive hearing test. This table is summarizing the ring test and Weber test. So, the ring test. In ring test, normally air conduction is better than bone conduction, which means ring test is positive, but in a conductive hearing loss, bone is louder than air, which means the ring test is negative, and in a sensorineural hearing loss, air is louder than bone, like it is in a normal one, but they're both reduced. So it's a ring positive, false positive. And in Weber's test, sound is heard in the midline, normally. In a conductive hearing loss, the sound is heard in the bad ear, and in a sensorineural hearing loss, sound is heard in the good ear. Thank you.
And now with management of deafness, being discussed by Halima, Shuaib, Ibrahim.
Hello, my name is Halima, Shuaib, Ibrahim, and I want to talk about the management of deafness. First is by removing the wax blockage. Airwax blockage is a type of reversible cause of hearing loss, and it can be removed by using a suction or a small tool with a loop on the end. And then the next one is hearing aids. If there is hearing loss that is due to damage to the inner ear, then hearing aid is the only helpful solution. And also the audiologist will discuss with the patients the potential benefits by using a hearing aid which will fit with the device. Open fit aids are currently the most popular ones, and they are used due to its fit and features offered. It is also indicated when this hearing aids is only indicated when medical or surgical treatment fails to regain hearing. That is, if there is no other thing to do, then the only solution for the person is hearing aids. And then we have principles. A microphone is to collect the sounds and transfer it to the electric signals. And then amplifier will amplify the electric signals, that it will increase it. Then receiver, it will transfer the amplified signals to the acoustic signals. The next one is the cochlear implant. The cochlear implant uses a sound processor, and it is worn behind the ear. So unlike a hearing aid that will amplify sound, that it increases the volume of sound and it directs it into your ear canal, a cochlear implant will bypass the damaged or non-working part of the inner ear, and then it will directly stimulate the hearing nerve. It is also surgically implanted electronic device which is coupled by external components to stimulate the auditory nerve, and it is indicated in cases of bilateral total sensory loss, and the auditory nerve should be intact also. The device is composed of external and internal parts. The external part is outside the skull. There's the microphone, the speech processor, and the transmitting coil. While the internal part, the receiver is placed surgically beneath the scalp in the posterior auricular area over the mastoid. An electrode is internally implanted in the scala tympanic through the round window to directly stimulate the neural fibers. And the last one is selection of patient. Selection of patient, there is postlingual deafness and prelingual deafness. Postlingual deafness, it is the deafness that occurred after there is completion of speech development. That is, the patient can return to hearing world after cochlear implantation. Prelingual deafness, it is a deafness that occurs prior to speech development. This patient will not get the same benefits as the postlingual ones.
And now, here is a short note on congenital laryngeal stridor, laryngomalacia, or shortly and commonly known as stridor. Discussed by Khadijah Abdullahi Aminu.
Stridor. Stridor is a high-pitched wheezing sound caused by disrupted airflow. It is a difficult, noisy breathing due to obstruction of the airway, that is either the larynx, the trachea, or the bronchi. It affects children more often than adults. There are 3 types of stridor: inspiratory stridor, expiratory stridor, and biphasic stridor. Inspiratory stridor indicates obstruction at the level of the larynx, that is either the glottic or the supraglottic area, and the sound is often high-pitched. Expiratory stridor indicates bronchial obstruction, as in bronchial asthma or foreign body in the bronchus. Biphasic stridor, that is both the inspiratory and expiratory stridor, indicates subglottic or tracheal obstruction, that is malignant thyroid, lymphadenopathy, and mediastinal tumors.
And now we have causes of stridor. Discussed by Radwa, Magdi, Zaghlul.
Now I'm going to talk about causes of stridor, which includes congenital causes such as laryngomalacia, glottic web, subglottic stenosis, and vocal folds paralysis. There are also traumatic causes such as foreign body and chemicals inhalation or injury during operations. And inflammatory causes would include acute nonspecific laryngitis, acute epiglottitis, and diphtheria in children, while in adults that would be chronic specific laryngitis such as laryngeal scleroma, syphilis, and tuberculosis. Neoplastic causes of stridor include multiple papilloma in children and malignancy in adults. There are also allergic causes such as laryngeal edema or neuromuscular causes such as bilateral abductor paralysis. Then there is laryngismus stridulus, which is an apyrexial laryngeal spasm causing stridor at night only. It is common in malnourished children with vitamin D and calcium deficiencies.
And lastly, we have first aid and management of stridor. Discussed by Arwa, Mohammed, Fadlallah. First aid for stridor, which is basically harsh sound with breathing in. Breathe warm mist in a closed bathroom with the hot shower running. Do this for 20 minutes. You could also use a wet washcloth held near the face. Caution: do not use very hot water or steam, which could cause burns. Management for stridor. Treatment should include oxygen, humidified if possible, dexamethasone oral, unless swallowing problems, then IV, nebulized salbutamol, and treatment of any infection. If severe and not improving and conservative, then management may need to consider tracheostomy if upper airway obstruction, discuss with on-call ENT, and nebulized adrenaline, discuss also with senior doctor used to giving this. Definitive treatment includes radiotherapy if appropriate, discuss with on-call clinical oncologist, and laser or stenting for tracheal obstruction, discuss with local respiratory team. If no other treatment options, then make patient comfortable with sedation. Always discuss with senior member of team. And lastly, consider Helix 80-20 if available. Helium-oxygen mix, which is less viscous than air and easier to inhale past obstruction. Thank you for watching. I hope you liked our video. You may check the references in the description box down below. See you next time.